Anthony Burgess, who's a very credible author, once said that it's terribly important, the first line, in order to draw people in. So I hope I've not got you here under false pretenses that. He's right, actually, in terms of certainly people remembering things. I read one of his books, Earthly Powers, when I was 14. And it just occurred to me this morning, actually, I can still remember the first line from it. And that first line is, it was the morning of my 75th birthday when, and I was in bed with my favourite catamite, when Ali, the butler, called to say the Archbishop was downstairs. Not a bad introduction. Anthony Burgess also had real content in his novels as well. Now, you'll be the judge of that, but I can promise you a happy ending here, so let's crack on. Okay, so this is an incremental approach to creating electronic patient records. You're all in that business. That's what we're all talking about in various different ways, forms, etc. There are various mechanisms for getting people to pay for it, to contribute to it. And this is a new way that we think will be, well, we think will be very interesting to people. As said, I'm Nick Harte, and I'm Solution Director for ISoft, a CSE company. So what are we talking about? We're actually talking about implementing, well, people use different terms. Clinical 5 is a term used, electronic patient records, EPRs, essentially a supporting infrastructure for clinical and administrative processes and communication across the healthcare enterprises. Typically having a PAS, some kind of context management, patient identification and management system, scheduling tools to organize both resources and patients and practitioners. Electronic prescribing is a key element. Clinical narrative, clinical decision support, care planning, pathways, workflow, they sort of blur really, but they're all in the same sort of space about coordination of resources and communication of information. That's what it's all about really. And Audicom's results reporting is just a very, very early version of that sort of technology. We're talking about here of actually putting this in an evolutionary, sustainable manner. It's important to know where you want to end up. One of the most IT literate and well-supported organizations in the world would be Partners in Boston, who have over 350 systems, and it is almost unsupportable. So they have more IT than you could dream of, and it's actually getting in the way now of communication. It's getting in the way of flexibility. It's getting in the way of reorganization. And so that's quite important to know as we start to do things in an incremental fashion, which is what I'm going to be talking about, where you want to end up. You want to end up with completeness, not complexity. Key along the route is actually sweating your assets, so getting everything you can out of what you've already bought. Now, you'll mostly feel that you've sat for the last 10 years perhaps sweating your assets and you'd like to get on and innovate. So you have to be able to do both things together at the same time. Without, as you innovate around the edges, potentially putting yourself in a position where you can no longer afford to support this. Another key thing is the traditional routes towards an electronic patient record rather indicated that you went in a certain route, possibly results reporting first, then order communications, maybe those two together, then bit by bit departmental systems, discharge summaries, things like that. And actually one of the things that derive most value, which is electronic prescribing, although mandated in virtually every procurement I've seen for an electronic patient record over the last 25 years, has hardly ever been delivered. And it is actually very, very deliverable. And actually, it's one of the things you should probably think about putting in first, because you will get immediate, demonstrable, recognizable value from that in every sphere. Okay, so future-proof. So if we're saying you want to get on and you want to do stuff, and you want to do stuff not necessarily in the traditional electronic patient record order, you actually have to work out what it is you're doing. Is that sustainable? Is what you're putting in place actually going to be sustainable in 5 years' time, or is it going to be a problem in 5 years' time as it doesn't fit into an infrastructure? It's getting easier. It's getting much, much easier as systems become more standards-based, as they become service-oriented. That means that they are more interoperable, that they will support business process, engineering, and also cloud enablement. Cloud enablement is, well, particularly perhaps by me, not particularly well understood. But what it essentially means is a dynamic support structure, a dynamic hardware environment that would allow you to scale and do a number of different things, which are simply impossible when your servers are in your local server room, under your desk, or wherever it should be. So it is very much a technology which is going to enable things. It's not about hosting. It's absolutely not about hosting. Anything you buy today needs to provide a strategic bridge to tomorrow. What does that mean? That means that it has to be interoperable. It has to fit into the environment that you have imagined you're going to end up with to support your clinicians, to support your administrative staff. And it's important to bear in mind that you will only get one shot at this, physically, mentally, intellectually, organizationally. We are not capable of doing many more than one of these. The quote at the bottom there, I will place the adverts, I'll just quickly see if he's in the room, actually. And he isn't. Okay, so I won't name him. Had he been in the room, I would name him. This is from a CIO of a large organization who said, I will place the advert for the replacement EPR on the same day I hand in my resignation letter. It's taken me 10 years to get to this position. I'm not doing it, actually 15 years. I'm not doing that again. And that's true. But more importantly, it's not about the individuals, it's about organizations. Organizations' ability to absorb the kind of disruption that is implicit in these things is very limited. You have to do it once and you have to try and do it right. And you have to think long term. You can't be thinking, we'll pop this out in 5 years' time. But you do need the flexibility to be able to do that. Okay, so I'm ISoft, a CSC company, a representative of ISoft, a CSC company. So Lorenzo, a name word I haven't mentioned yet, is what people traditionally associate the ISoft CSC EPR approach with. And that's, I think, probably seen as a result of the connection with the program as rather monolithic. Well, in fact, it isn't. It was originally designed as a framework, and this is going to talk a little bit around this here. It's a framework that will allow you to do a number of things. It will allow you to posit a future position which will be complete but not complex, and at the same time position things into that framework as you move along to take advantage of what you need today, to recognize that you have already invested perhaps in an order comm system. You've probably already invested in, well, you've got a PAS. Do you need to swap it out today? A lot of you won't do. But you do want to get on and do things which are traditionally quite tightly integrated with the PAS. So, for example, scheduling, and we'll come to that in a moment. So this is really about we call it smart solutions. Essentially, it's interoperable solutions that can be put in place today and will persist in some future state, whatever that is, whether that's an ISoft Lorenzo environment or whether that's a purely composite mashed up application that you create and manage yourselves. Whichever it is, we can ensure that the actual complexity of managing and maintaining that, which is terribly, terribly important in order to allow you to keep flexing it, will be simple. Okay. So ISoft EPMA, MedChart. It's an application, I think this is, so unashamedly, I beg your pardon, this was actually billed as a case study. I didn't see that it was billed as a case study. This is unashamedly us talking about some products we've got that we think you'll be interested in, and then talking about how we think you might get someone else to pay for them. So I'll crack on with that. But MedChart is an application not built from the ground, and this is like an exemplar of the sort of the mindset. This is not built from a pharmacy system as an adjunct to a pharmacy system. This is identified what the processes are within meds management and create an application which will fit in those, recognizing that it needs to talk to the back end to pharmacy, at the front end to clinical systems, the left-hand side to PAS, registration systems, etc. Designed to do that, designed for interoperability, smart. Clinical narrative service is another one. This is actually the first offering from Lorenzo outside of the program, which is actually, what we've done is we've said, what are the real issues in terms of joining up clinical teams, in creating a communication layer, in ensuring that we can pass information back and forth between the team, virtual or physical. And essentially, it boils down to a number of tools around clinical narrative, recording, communicating information. So we've isolated those, and we're now offering those into our base as discrete functionality that will persist and will in the future, because it is compliant with all the standards, the national standards, CDH, L7, et cetera, will persist in whatever future environment you have. And will allow you, because it's an enterprise-wide tool, not to create a Tower of Babel by sticking in a bunch of applications which support the immediate informational needs of the clinicians in various locations. That's what most approaches to that end up doing. If you don't think enterprise from the start, no matter if you're even starting in one place, you will end up replacing or not improving communication, hampering communication. Okay, so connecting the care team, sharing the records, supporting the processes, bringing in the departments, not allowing the departments to drive the agenda. Ultra-gender enterprise scheduling. I won't talk much about enterprise scheduling because we've got a session this afternoon, but we think this is one of the great untapped opportunities to radically change the way healthcare is delivered in the UK. Enterprise scheduling, and the enterprise is healthcare. It doesn't matter where you are, what system you're doing, what the resources are, you need to be able to connect them. Until you can connect those around the patient care plan or the patient program, then you're simply going to be struggling against the odds. We have systems that do that, but they organize around the four walls of that particular department or the walls of that institution. They do not consider a patient journey. There's almost nothing out there that does. And then replacing the engine. What is the engine? The engine of what we do really is your PAS, isn't it? So this is, so we can believe you can move forward adopting things, and then at some point in the future where it makes more sense to replace your existing PAS perhaps with a Lorenzo PAS which is interoperable with all these applications or fully, to absorb them into it to get the maximum benefits. But you don't have to do it in the first instance. Okay, so the evolved EPR. This is where a lot of us are. We have a PAS. Can you actually see that? You can, yes. PAS, EPR, some kind of clinical desktop tools for clinicians. Integration platform, actually typically more an integration engine is what you have. Linking you into third-party systems. And that's, I think that would probably describe most people's environment actually today. What we're saying is in that environment today, you can start to plug things in. You can start to plug in high-value things that will have an immediate impact upon the quality and cost of care and the outcomes to your patients. Immediate, absolutely without question. EPMA, MedChart. If we take that a little bit further, and instead of just looking at an integration platform, but actually talk about an enterprise platform, we can then start to offer in additional services to go across your entire enterprise. And these are, some of these are Lorenzo services. Smart solutions is what we call them: maternity, clinical documentation, or narrative services, multi-resource scheduling, as described for ultra-gender. And we can start to plug these in. Now, it's as simple as this, folks, on PowerPoint. Obviously, outside it isn't. Oh, I beg your pardon. What's it say on this side? Well, there you go. So that's the facility we haven't got round to automating yet. My apologies. Can you see over here? Essentially, the point being is that you can create an environment into which you can plug components, ISoft components, other components. It's an SOA framework. Moving away from your traditional PAS and clinical support into an integrated solution, which is essentially what people are now starting to install in Lorenzo. I mean, this is the integrated clinical and administrative support functionality in release 1.9 and 2. It's all your clinical processes, plus your order comms, results reporting, prescribing very shortly, etc. So far, we've still retained a bit of complexity here, although you don't quite know what's in it. Over here on this, we've got these in discrete modules. The future path for us is just to absorb these in and have these re-expressed as services within the framework. So you're gradually reducing the difference in exposure to your clinicians and gradually consolidating, providing completeness and removing complexity, both at the visual interface layer and also at the back end, and that's terribly important. All right, so straightforward enough. We'll all be there very shortly. Who's going to pay for all of this? Big Pharma will. And here's the thing, they will be more than happy to pay for this. Anybody from Big Pharma? It sounds like they're some shady organization. Okay. Big Pharma they face essentially something we call a patent cliff, which means that from the moment they put a patent on a drug, they have a limited amount of time, and they have to recoup their money within that period of time. So every day that they're not out there selling, conservatively costs them £1 million for any drug. So they have a huge interest in actually getting drugs to market more quickly. It's increasingly complex, the actual governance rules, the verification, accreditation, it's harder and harder. So they're looking for tools that will improve that. The traditional setup with recruitment management organizations is not really delivering that. It's actually almost part of the problem. What we're seeing now is some technologies come on the market that actually potentially offer a way of doing this very, very much quicker, improving recruitment, improving the quality of feasibility and the speed of feasibility studies, and then helping you manage through the actual trials themselves. And we have partnered with a company that allows us to do this. The company is called Clinicworks. They're largely installed in the US, where there's a bit of a history of this sort of stuff, but also elsewhere across the globe. We have, yesterday in fact, we signed a memorandum of understanding with Southampton University Hospitals to take the first installation of this software. And I'll tell you a little bit about it. But essentially what we do is we stick some software, a repository and some software into your environment, or we can host it, but we stick it into your environment, and then we just feed stuff into it. We feed stuff into it from pretty well any source. The application is designed, it has really quite sophisticated algorithms to extract information, create a credible database which you can then interrogate in a number of different ways. Research sponsors, they're the people who will pay for it. The other folks who need access to information, researchers across your institution. We've looked actually at the amount of money the NHS makes from research, and there are some organisations that make considerable amounts, several millions, let's say. It costs them a huge, huge amount to get that money. It's almost not worth doing it in many respects, apart from some of the kudos that goes along with being part of a research organisation. This can dramatically reduce the cost of actually getting the information. And it provides you with a whole bunch of other tools as well. It provides you with an automatically populated, structured repository that you can interrogate pretty well across your enterprise. And so far, we've not seen anything we can't push into it. The interesting thing is actually the information that we're already collecting within the NHS. Two simple sources can actually largely provide the information it needs that is of value to pharma. And we've obviously been checking with our big pharma partners as to the information they require. So very straightforward. Okay, so what do? We create a historic raw data, dump into an on-site repository, apply the rules-based apply the rules from Excel find into it, and create a de-identified database. All these sort of potential patient merges, all the questions are all sort of put to one side for analysis and management manually. You're left very, very quickly within a period of 2 to 3 weeks with a fully structured database. Web mining tools are then available to researchers, and that's entirely up to yourselves how you distribute that. New data is automatically uploaded and process continued. This isn't about traditional HL7 sort of interfaces. We can just take flat files. We can take pretty well anything. We can read documents. We can analyze documents as natural language processing. And it really all this stuff exists. I've just got a big 10. That's minutes, I'm hoping. Not seconds. All right. I'll rattle through this then. Okay. New data continually uploaded. It's pretty straightforward. And it costs you nothing. Nothing, no charge for the software. If you have a server, stick it on a server. If you haven't got a server, we'll put a server in. Okay, the technologies I've talked about, smart integration, you're wondering why, aren't you? Why would we do that? Well, we'll come to that in a moment, actually. Smart integration, uploading engine, natural language processing to take information from the various electronic documents that you have lying around, but which are uninterrogable at the moment. Dynamic data mining, analysis, etc., etc. None of it in itself is rocket science. It's all pretty damn smart, but actually this is a package which has brought a number of things together and made them available in the commercial model, which is, I think, very interesting. All right, so how does it work commercially? So for let's say a typical trust, just caveat this immediately, the figures here are from US experience. So without being rude, let's reduce them by a factor of 10, and it's probably still worth doing. So a hospital group with 1 million patient records, 1 million electronic patient records with the kind of information we're looking for can increase recruitment by 3,000 patients a year at an average of £5,000 per patient. Equals revenue of £15 million per year. Now, how many hospitals have 1 million patient records electronic? Everyone we've spoken to has, in one form or other, going back over history, and active in the region of 200 to 300,000. So you're already sitting on these kind of repositories today. Okay, so there is potentially enormous revenue. This is recognized. Andrew Lansley recognized this in his first speech, actually, at the conference last year. This was one of the things he identified as something we should be doing something about. Well, let's not wait for central government to do something about it. Let's individually do something about it. Okay, so why are we interested? Well, with that information from 1 million records, ISoft and our partners, we can conduct 1,000 feasibility studies, plus 10 to 20 recruitment projects. So we do a number of things. We basically act as an interface to pharma. Now, those of you who are already connected in will be connected into a subset of the wider pharma organization. So essentially, we're acting as a broker as well. We're exposing the information you have in a completely anonymized way to larger companies who actually will then use it to assess whether or not it's worth their while even bringing this drug. So there's no data, there's no information being shared whatsoever. There's just, what is it? It's information. It's not, it's not patient data. It's information about patient populations. So two things. We can expose you to a much wider field, and also we can collate your information and thereby add value to maybe a small number of potential recruits that you might have to a number of recruits from other organizations, and therefore bring together, very much in the way that Lansley is talking about, actually bringing this together in a very, very simple, straightforward fashion. And there are significant revenues for ourselves there as well. There's a demonstration just of that software, the Clinicworks thing, at clinicworks.com, Excel find. It's very, very straightforward. It's a tool which is designed to be used by peoples, not by by data miners, whatever they are. It's designed to be used by clinicians. It's designed to be used by researchers. Okay, so that's it. So to summarize, we can offer today a mechanism which will allow you to incrementally build an electronic patient record, as can everybody. But we can take it a bit further than that. We can offer you an endpoint that is not an endpoint of total complexity and you're on your own now, manage and support this, but will gradually absorb what you have into a wider structured platform, which you can then have some options as to who manages that, who supports that. And I think that's terribly, terribly important if you don't want to end up like partners with 350 systems and no ability to manage it.